Our mission statement: through our exceptional healing care, we revealed the healing presence of God. That's the way we hope you feel when you are here with us. We did our introduction, Shelley and Sherry, nursing and physical therapy. The paperwork that you have in front of you is additional paperwork we've given you for you to review at home. And this is like some of the tips and tricks that the floor has put out in why we do things here at the hospital. There's a paper in there that's explaining what we want you to do at home to get your home ready, and Sherry will speak to that more so in her presentation. You're going to be receiving a folder when you get here, and in that folder you can tuck all that paperwork, and that folder is going to contain all the paperwork you're going to get while you're here too. Someplace to help you organize yourself, and so when you get home, you know where to look for your paperwork. Ouch, ouch, ouch. This is where we expect you all are right now. This is the way you're feeling. Okay, next one. So you have all done conservative treatments for your arthritic joints, and the doctor is telling you it's probably time to do surgery. You've gone through the weight reduction, you've changed your diet, you've tried to increase your exercise, you've done pain medicine, you've probably done injections into your joints, and you're still feeling rotten right now, and you want it fixed. You and your doctor are conferring, and you're saying that it's time for surgery. This is for our knee people here. This is what your knee wants to look like. That's the way you want it looking, but this is what it's looking like right now. And you see that it's crushing into each other there. That nice space of cartilage is missing, and you have bone-on-bone crushing pain. So this is x-rays. This is the way you're feeling right now. This is an x-ray of what you're going to be looking like after your knee replacement is done. And you see that nice cushion of space is replaced, and you have a nice gliding surface there for your joint to move freely. So knee surgery is considered the gold standard for treatment for arthritic joints. It is not a replacement, but it's a resurfacing of your bones that you have. And our hip people. The hip x-rays are a little more difficult to see, but here again, you have a nice space where that ball of your femur can glide and move in, and the way you're feeling right now, they're crushing in on each other. So once again, this is the way you're looking and feeling right now. And over on the right, you can see how you have that nice metal ball gliding in your hip joint again. With a hip prosthetic, you can see that the top of your thigh bone is removed, and the shaft of the joint is down into your femur there. So the way a hip will differ from a knee, it's still a resurfacing of your cup, but we do have to remove the top of that femur bone so that that shaft can be stabilized. The head of the shaft can be stabilized. Okay? So when you're preparing for surgery, we ask that you find a pal. The pal is going to be your best friend, the person who is willing to do anything for you. They're the ones that are going to be getting up in the middle of the night with you and making sure that you get to the hospital on time. They're the ones that are going to be available to get you home when it's time to go home. In preparing for your surgery, you will all be asked to have what we call a pre-anesthetic surgical visit. And at that visit, you're going to visit with a nurse from the surgery department. She is going to obtain all of your health history. She wants you to bring a list of medicines, a complete list of medicines, which means name of the medication, the amount, and how frequently you're taking it. She's going to input all of that into the computer. Blood work will need to be done. If your primary physician is not requesting blood work for you, it can be done at this visit. Generally what she does is she sends you up to LabCorp on the 3rd floor, and they do it. After all of that is completed, the anesthesiologist will visit with you, and he will discuss your surgical options. For those of you who are having a knee replacement, he'll also talk about that nerve block that can be done to help control your pain postoperatively. Final say in if the surgery can go forward or not. So I do recommend that you keep in touch with your primary doctors while you're planning this surgery. And if any of you are seeing specialists like a cardiologist, endocrinologist, or pulmonologist, you keep them in the loop that you are planning this surgery, and get into their offices to have a checkup so that you can have their blessing for this surgery and we can go forward with it. We did. So in the packet that you received prior, that Sherry handed out, there is a paper on nutrition. Nutrition plays a very important part in how well you're going to do with your surgery and with your healing postoperatively. With a joint replacement surgery, they are recommending high protein diet. And they want up to 100 grams of protein every day. That's a lot of protein for you guys to take in. So start thinking now about what you want stocked in your refrigerators. There's cottage cheese, there's other cheese. Some nuts are very good for you to be snacking on. Hard-boiled eggs make a good snack. But just think protein. Try to change your diet habits now to increase your protein, and keep that up after surgery. We also want you to eat foods that are high in fiber. So that's increasing your fresh fruits and vegetables. Constipation can be an issue after surgery because of your inactivity and because of the amount of pain medicine you might be taking. So they also recommend that your sugary drinks are eliminated. Water is always good, fruit juices are good, milk, tea, but they really would like you to minimize the soda. When you're packing to come to the hospital, you are allowed to pack anything you want. The therapists like you to be comfortable. Shorts are good any day of the year for them. They like to be able to see your incisions. Elastic waist is good. If you're having a hip done, you're going to have swelling in that joint, and elastic waist is best. Sweats, the pajama pants that they make now are nice and loose and comfortable, and you can go from bed to chair to therapy room in them easily. We ask that you have sturdy shoes. Any of the lotions and potions that you ladies have and like to use. When you are doing your showers, we ask that you don't put anything on, but you can bring your favorite scented lotion with you and start using it again here at the hospital. Some of you like to read. Some of you have certain snack you want packed along. We are Wi-Fi connected, so you may pack whatever you want. So infection prevention is going to start at home. And you're going to see Beth. She's that pre-anesthetic nurse testing visit that you're going to visit with. She's going to send you home with a bottle of this chlorhexidine. You are going to shower the night before surgery. You're going to use this on your entire body except your hair, your face, or your private area. It is harsh. It is cleaning. It's the first step to preventing an infection in your new joint, and that's very important. The morning, you're going to have clean sheets on your bed, put clean pajamas on your body. The next morning, the day of surgery, you're going to get up and you're going to shower again using this, the same way. Use it on your body. Do not use it on your hair, your face, or your private area. But the rest of your body gets this. You're going to get another towel dirty for your pal to do the laundry for you. Don't use the same one that you used the night before. You're going to put your clean clothes on and you're going to come in for surgery. It is extremely important that you do not have any infectious process going on when you come in for surgery. You do not want to get a joint infection. So, that being said, if any of you are coming down with a cold, a bronchitis, an ear infection, a urinary tract infection, if you feel any kinds of symptoms of unwellness, please call your doctor. If it's a week before your surgery, check in with your primary, remind them that you're having this joint done, and see if you can't get on an antibiotic and get taken care of. If it's a day or two before your surgery, you do need to call your surgeon, and he will make the determination if we can continue with your scheduled surgery or if we need to reschedule you. You do not want a joint infection. So, I'm sure all of you know the rule is nothing to eat or drink after midnight, the night before your surgery. When you see Beth at your pre-anesthetic testing visit, she will tell you which medications you may take the morning of surgery with the tiniest sip of water possible. You're going to arrive at the procedure center. The parking lot is really pretty well labeled. Right now you're like in parking lot C at the hospital entrance. You're going to go around to the procedure center, which is parking lot H. Your pal can drop you off at the doors if you don't feel like walking in all the way, and then they can go park the car and come in and meet with you. You should bring your insurance card and your picture ID so that you can get registered. If any of you are on using inhalers, they will want you to bring your inhaler with you. Occasionally, the anesthesiologists like to redose you right before you go in and are put underneath the anesthetics. Your living will and your power of attorney, any of your healthcare directive paperwork, you can bring that when you come to see Beth. And if you forget it, now is a chance to bring it again so that it can be scanned and input into your chart. So morning of surgery, the question is, who are you going to see? When you arrive, you're going to be admitted. Insurance card and picture ID is going to be reviewed. You're going to be put back in your procedure center room, and your family stays with you when you go there. Once the nurse has re-asked all of the questions you told Beth, you're going to be visited by your doctor. Any last-minute questions can be asked at that time. You're going to have him initial the correct joint that is going to be operated on for the day. And that's a very important safety precaution. While you and your doctor are both there together, you are agreeing which joint is being worked on. One last time. After the surgeon visits you, the anesthesiologist will visit you too. Blocks will be taken care of at that time, and if you have any last-minute question for the anesthesiologist, you are free to ask them. So this slide is mostly for your pal. All of you have been told by your doctor that the procedure is going to take about an hour. And the pal is sitting there in the waiting room wondering where you are. So it is 15 to 30 minutes once you are in the operating room before the doctor comes in to start the surgery. They have to prepare you with the last surgical scrub. The anesthesiologist has to get you to sleep with the anesthetic, and they have to open up all of the sterile field that will be used and your new joint parts. The doctor will come in and do his work, and it will be about an hour. It's going to take a little longer before you are out of there, because once he is done, somebody's going to be dressing and closing up his incisions. When you are moved to the recovery room is when the doctor will come and speak with the family members and the pals that are here. Let them know how the surgery went. Once you are done in the recovery room, you'll be moved to the floor. Unfortunately, we are having a delay in getting you from the recovery room to the floor. Our volume is very high right now, and we need to get people discharged, rooms cleaned, before we can get you up there in a bed. So we are having a delay right now, and it can be excessive, 3 and 4 hours at times. If that is the case with you, your family member, your pal, will be able to go into the recovery room to visit with you for a few minutes so that everybody can see each other eye to eye and know that everything is okay. It won't be a long visit, but you'll be reunited as soon as possible up on the 2nd floor. Okay. No, we're good here. Hospital stay. So this is a picture of the room that I get to welcome you to if you haven't been here before. All of our rooms have nice large windows in them. That's really a great asset. That is considered the family area of the room. If your pal is spending the night with you, this is the love seat that can open up into a bed that they can sleep on. Some people like to sleep on the hard bench. It's narrow, but it is much more firm. You can see where your flat screen TV is up there. And of course, the area to the off screen here is my favorite area of your room, and that's where your refrigerator is. I really like the refrigerator. So you can see the bathroom door. It will be the 1st or the 2nd day after surgery before you see the inside of your bathroom. Depends upon how you are moving with your physical therapy. You will all arrive on a bed placed in the middle of the room. The area to the left of your bed is my work area. I have my computer over there. Your vital sign machine is over there. Your medicines are locked up over there. On the left side of my room, you'll also notice I have hand sanitizer, and that is for everybody to use, not just me. Everybody walking in and out of your room should be gelling in and gelling out, we call it. We ask that visitors and family members, and even you as our patient, use that gel. We want to keep your joint infection free. Another safety consideration, you'll notice the picture of the white band. That white band is put on you once you're registered. I will be scanning that multiple times while you are here. When I scan it, your personal med sheet opens up in my computer. So that's another safety consideration. I will be asking you name and birth date multiple times while you are here. And food service workers will be asking you, physical therapists will be asking you, the lab people at 4 a.m. will be asking you. So we really want to know your name and your birth date. We want 2 patient identifiers so that the correct activity treatment is done for the correct person. When you arrive in your room, kind of a flurry of activity takes place. We're going to have the blood pressure cuff wrapped up on your arm still. We're going to need to be checking your vital signs frequently. A little square probe is going to be put on your finger, and that's checking your oxygenation. Many of you will come with oxygen flowing in your nose when you come back from surgery, but some of you won't. Do not be surprised if I, as your nurse, am putting oxygen on you in the evening if you haven't had it yet. It is very, very common to use oxygen the night of surgery. You're going to arrive to me in your new favorite color accessory, yellow gripper slippers. So one of our things, grippers on both sides to help prevent falls. We don't want any injury done to you with your new joint. Your IV fluids are going to be placed on a machine. That machine's going to make sure that you get the correct amount of fluid. I need IV access for 2 reasons, and the first one is for your postoperative antibiotics, and the second one is for pain medicine when we need to give it to you. Catheters are going out of vogue. Most doctors do not place a catheter routinely anymore. The reason being, it is a source of infection, or it can be a source of infection. So, if needed, we can straight cath if there's an issue. So, your surgical dressing. This is what we like to see underneath all of your surgical wrappings. This is what we call an aquacell dressing, and I think the majority of our doctors do use this now. So an aquacell dressing is impregnated with silver to help fight infection. It's placed on you in surgery in that sterile environment, so it's the safest that we can possibly make it. As long as it remains intact on all 4 edges, it is waterproof, so you may shower with this dressing on too. This dressing can stay on for about 5 to 7 days, as long as it remains intact. So it's placed in surgery, no better place to have your dressing applied. So that's one of the dressings that we use, and like I said, the majority of our doctors are using that one now. And activity. Activity the day of surgery, most of our doctors are now asking for physical therapy to start the day of surgery. You are coming to us as healthy as possible, and the goal is to get your life back together. So we're going to work towards that goal, and we're starting out the day of surgery. All of our physical therapists are see you individually. So Sherry and I will confer. You're doing great. Your vital signs are great. She's going to work with you and get you up to a chair. I'm going to tell her, you're really sleepy from that anesthetic. You're having a bit of pain. Your blood pressure is on the lower side. Sherry's going to come and exercise you, and we're going to, see what you are capable of. All of our therapists are very good at doing it one-on-one, especially the night of surgery. So your most important question is, what can you eat? And you're getting me, and I'm the old nurse on the floor, so you get sips of water and chips of ice. If you're not having any nausea, it is appropriate to have a light meal the night of surgery. And this is one of the reasons why I like your refrigerators, because I like you to order something that we can tuck in that refrigerator, and when you're awake at 10 or midnight and you're hungry, really hungry then, there's a snack in there that they can get out for you. So a cup of fresh fruit, a carton of yogurt is always good to be stored away in there. So breakfast the next day is the meal you really should plan on enjoying, and the first meal. You're going to order all of your meals while you are here, and you're going to dial that 3463 number, and you don't have to memorize that one right now. It will take about 45 minutes to get the tray to you once it is ordered. And if your pal is spending the night with you and staying with you or visiting you during the day, they can order what we call a guest tray. They pay $7 to the food service worker per card when it's delivered, and it seems to work out really well. Okay, now all surgeries do come with potential complications, and we are going to avoid our complications. First one, you've heard me talking about it already, is infection. You're going to come to us as healthy as possible. They're going to be doing a nasal swab on you to determine if you are a carrier of staph before surgery is done. You're going to be using your chlorhexidine as prescribed. You will receive antibiotics immediately prior to surgery, and then I will complete them up on the floor for you. We're going to be gelling in and gelling out, and you're going to be asking for some gel soap so you can wash your hands too. We're going to prevent an infection. And this note at the bottom here, I do want you all to have a conversation with your dentist and with your surgeon. And the question is, do you need to take antibiotic treatment prior to any dental work? There's new studies on it. It used to be always you did it, but you need to have that conversation and make the right decision with your dentist and your surgeon. We are going to prevent a blood clot. Blood clots are a risk with orthopedic surgeries. All of your surgeons are ordering a particular medication to thin your blood to prevent blood clots. So you will be on one of these, not all four of them. Coumadin used to be the gold standard and everybody was placed on Coumadin. It is no longer routinely used. If you are currently taking Coumadin for some other comorbidities, you will be placed back on it after surgery. Currently, aspirin, full strength, and that's the 325 milligrams, not the baby 81s. Aspirin is used twice a day. That one is used very frequently with our doctors. We have a few select doctors who prefer Eliquis. And all of these medications will continue per your doctor's recommendations. It's generally in the time frame of 2 to 3 weeks. Xarelto is the fourth medication that could possibly be ordered. Xarelto is a little more pricey, and the case manager can help you work through if you need to continue Xarelto at home, and there is some monetary issues there. Other interventions that you can do, and we will do, to help prevent blood clots are the white TED hose, and these pictures aren't very good, I'm sorry, but I think some of you have had surgery before and you've had those white compression stockings on and you know exactly what I'm talking about. So, support stockings, TED hose. The middle picture is what we call an SCD or a sequential pump. That is wrapped around your calf with Velcro. It squeezes you intermittently in 3 parts on the back of your calf or around your entire leg. And what that does is that helps that blood to not pool in your calf and to flow back to your heart. Most people, when we put those SCDs on, they feel like they're getting a massage. So I hope that's the way it is when yours go on you. Those are used in bed while you are here. And then the ankle pump, the bottom picture, that is a wonderful thing that you can do, that nice and rhythmic, all the way down, all the way up, nice and smooth, pumping it all the way down, all the way up. I like ankle pumps too because when you're doing those ankle pumps, you're not letting your thigh muscles tense up, and that helps to reduce your pain. There we go. That's okay. Incentive spirometry. Nobody's going to go home with pneumonia. We will give this to you, tell you how to use it, encourage you to use it while you're here. And I'll encourage you to pack it up and take it home with you and use it there still. And our last issue that we want to talk about is constipation. Constipation tends to be a problem post-operatively with orthopedic people. You are not moving as freely as you want to or as much as you want to, and you are taking more narcotic pain medicine than you are used to. So for those reasons, constipation can be an issue. We ask that you increase your fruit and fiber. Your doctors are going to start you on stool softeners the night of surgery, most likely, unless you're nauseated. And then I just want you to know that after all of that is said and done, you very well might want to take a suppository before you go home, and I'll be glad to help you with that. You will feel much better if your bowels move before you go home. It's one less thing you have to worry about or send your pal to the drugstore for once you're home. So, pain management is important, especially with joint therapy. Your anesthesiologists are for our knee people, are going to talk about doing a block, which is going to help control the pain to the top and the sides of the knee. The block does not reach the back of the knee. Your nerve doesn't run back there. So, if you are currently taking narcotic pain medicine, they ask that you cut back as much as possible so that it can be more effective after surgery. And our goal is to make your pain tolerable. Actually, I have two goals for your pain therapy, and that's so that you can do your physical therapy to the best of your ability. And the second one is to get some rest so that you can do your physical therapy to the best of your ability. Because that is what is so important in doing well and getting out and having a good outcome with your joint surgery, is your participation in physical therapy. So while you're here, you're going to be asked to rate your pain on a number scale, 0 to 10. And you can see if you are at a 10, you're not thinking about what you're going to be putting in that refrigerator to store away for a midnight snack that day. But our doctors are giving us a variety of medicines, oral and IV, and we will ask you what your pain number is. We will tell you what your options are. We'll talk about it. We'll make a decision. And what we do not want you to do is be sitting in that bed if it's horrible, horrible, and you're just waiting for 4 hours to elapse so that you can get another pain pill or something. You need to let us know, because we do have a variety of options, and there's other things besides medications too that can help. There's other options besides medicines for your pain. This is why I like the big window in everybody's room. It gets your mind off of the four walls of the hospital and you see the outside world. I think that's very important. All of us are firm believers in ice therapy. If you are a hip and you have ice, well, actually, we just moved to new gel packs, and they're going to get them, aren't they now? The hip, aren't they? Oh, okay. That'll be good. That'll be good. We just moved to a new gel pack system. It wraps around the knees easily. Our hips used to just have an ice bag, and they would melt faster than the gel packs. So the hips are going to be in much better shape now. Yeah. But I, as your nurse, can refresh your gel packs at any time you want. You just have to let me know. I'll be glad to do it, because ice is very good at decreasing your swelling and helping to relieve your pain in your joint. Some of you are not back sleepers, and you've been on your back now for 24 hours. If you let me know that you'd like to reposition, I will be glad to help you reposition over to your side. If you're a hip or a knee, I can get you repositioned with pillows, and you might become immediately much more comfortable. Of course, the refrigerator is important, because some of you are going to be getting those lovely love letters and cards and colored pictures from the grandkids. And that's why you're doing this, to get your life back and be active with them again. So I like to post those up on the refrigerator. You can see that refrigerator from any point in the room, so you will be seen and being reminded that your grandchild loves you and you are doing this for them. So, and that helps you get through a lot too. So, oh, and families in charge of distraction. That's for pain control. Yeah, take your mind off of it too. Your discharge planning. That starts the day after your surgery. And Gina is my case manager. She will be coming in and she'll be asking you what your home situation is like. Our goal is to get everybody home. You heal better in your home environment. So that's what our goal is. Occasionally, we have to send somebody to a skilled facility for additional rehab, but our goal is to get you home. So we ask that you enlist your friends and family and help them make that happen. So once Gina meets with you, she will then make sure that you have equipment that you need and that you have the home care company that you want to come into your home is all lined up so that we can have a smooth transition from hospital to home. I get to sit down with you and we talk about the paperwork that the doctors have me print up for you. We want to make sure you know what you're going to do with your dressing, what your signs and symptoms of infection are that you're watching for. We want you to be aware of what your new prescriptions are, how you're going to be managing your anticoagulation, how you're going to be managing your blood thinning medicine, how you're going to be managing your pain medicine. We want you to be knowledgeable about all of that before you go home. We want you to make sure that the home care company is available to you, your follow-up visits with the doctor. Any questions that you have, I really want them answered before you leave. And if I don't know the answer right off, I will be glad to find out for you because we want you safe at home. Discharge is happening sooner than later these days. So, if your surgery is on a Tuesday, I always expected you to go home on a Friday. Now, if your surgery is on a Tuesday, there is a good chance that you could go home on Thursday, depending upon how well you're doing. It depends upon how you are progressing. It always does. So then we are looking at Monday surgery. If your surgery is on a Monday, I used to always send you home Thursday. But now I am sometimes sending you home on Wednesday. If I'm sending you home only 2 days after surgery, you will have 2 therapy sessions that day before you go home. If I'm sending you home on my standard schedule, what I still think is a standard schedule, surgery on Monday, discharge on Thursday, surgery on Tuesday, discharge on Friday, you will go home after 1 therapy session. So we ask that your pal is available to pick you up so that we can get that room turned over for the people that are waiting down in the recovery room for your room again. So it will depend upon how you are progressing in therapy.
Today I'm going to give you some information about what to expect from your therapy while you're in the hospital after your hip or knee surgery. I move around a little bit more, so bear with me. I'll be doing some demonstrations and things as well. All right, Shelley. So, go forward. You're going backward. That's up there.
Oh, I just thought I had to
Okay,
do it.
and that's the next one. Okay. All right, so just a little bit of information about what to expect. We, as Shelley mentioned, prepare you for home. Our main goal is to get you out of the hospital and back to your home environment where you can recover, hopefully with home care. We're going to make sure that you're performing exercises before you leave the hospital that will equip you to continue those at home and with your home care therapist. We're going to make sure that you're using a walker safely when you leave the hospital. We'll make sure that you're able to climb steps if that's necessary to function to get into your home or once you're inside your home if you happen to have a 2-story or a split-level home. We'll also make sure, as Shelley just mentioned, about equipment. So if you need a walker for home, or you're interested in maybe a portable commode or a riser for your toilet seat, we'll make sure that the case manager works with you. We'll let her know what you need, and she'll make sure that's ordered and delivered to your home, or pardon me, to your room before you leave the hospital. We'll make sure that walker is adjusted for your height as well. Now, your goals from us, as far as the therapy is concerned, again, we want to help you with pain control in conjunction with your therapy, so we'll make sure the nurses know when we're coming back, or if you need medicine and we're going to go see someone else and then return to your room, because we want to make sure that you're able to tolerate your therapy as much as possible and be as comfortable and productive in the exercises and the walking as you can be. You can communicate with us any concerns you have or things that maybe we're not touching on during the therapy sessions, so that we can kind of gear it more for what you need to know before you leave the hospital. And then again, your goal is to be able to participate in all that activity. So we're going to talk a little bit now about exercises that are probably good to start before you come to the hospital. The stronger you are before surgery, the better you will do in your recovery. So just to kind of familiarize your muscles with a few of the exercises ahead of time, as long as your pain allows, is a good idea. And when you get your joint replacement book, when you come in to see Beth, or the doctor's office, I guess, gives that, there are pictures of the exercises in that folder, on that information that you get, so you'll be able to start some of these. Shelley talked about the ankle pump exercise, and that is done, as all of them right now, in the bed, laying down, just pumping your feet rhythmically back and forth. You can either alternate left and right with your ankles, or you can perform them at the same time. Again, good for circulation, good for the use of the muscles below your knee. Another exercise is what we call a quad set. Now, a quad set exercise, I'm going to kind of make some room up here and kind of show you a little bit about this next exercise, 2 of them, in fact, that you'll be able to do before you come in. The quad set and the glute set are what we call isometric exercises. There's not a lot of mobility, but you're going to be contracting the muscle. So when it comes to the quad set exercise, you can see the leg is flat. You're going to be tightening up the muscle on top of your thigh and trying to press the back of the knee down against the bed in this case. And then you're going to hold for several seconds, you relax, and then you would repeat that again. So you're just turning it on and off. There's not a lot of movement up and down. You're just tightening and releasing, and just pressing it down and releasing. Similarly, with the buttock muscles, they call those the gluteus maximus, but you're going to basically be tightening up your back end, your bottom end, and hip muscles, and you're going to tighten those muscles while you're laying down. You'll contract and relax those muscles. Again, you can hold for several seconds, working up to a count of 5 if you're comfortable enough to do that. And all 3 of those first exercises that I mentioned are done by our hip and our knee patients. So everybody will be doing these after surgery. Now, the exercise in the middle is a very important exercise, also done by both our hip and knee patients, and it's called the short arc quad, or basically you're straightening your knee. And a lot of people at home get creative with something that they can use beneath their knee. In the hospital, we have a tube or kind of a roll, a foam roll that we put under your knee. At home, you can use a coffee tub if you have one. You can use a rolled up thick bath towel that you can fold and roll. But what you're doing is placing it beneath your knee and just in that crease there, and you're going to extend and straighten the leg. So you're using this muscle again, but now this time you're moving and straightening and lifting the leg. So again, very important, it's using the muscle between the hip and knee, and that's good for both of those joints, the hip and the knee joint. Now finally, the straight leg raise, which is this last one here, is done with primarily our total knee patients. Our hip patients will probably do this as they progress in their recovery, but in the first 2 or 3 days, we don't start that in the hospital because it's a little more aggressive on the groin and hip muscle, so it's a little too soon to start in the hospital. But for our knee patients, right off the bat, we're looking for you to Basically bend your good unoperated leg and then lifting the leg that had surgery about maybe 8 to 10 inches or off the bed. So you're not looking to see how high you can go, you're looking to see how straight you can keep your knee, and then once that gets stronger and less painful, you'll be progressing to holding it for several seconds as well. But in the hospital, we're really wanting to get that muscle started, and that's really important for keeping your knee straight and helping with your walking once we get you up on your feet. Now, most people start physical therapy, as we talked about, maybe on the day of surgery now, depending on the surgeon. And if we're beginning your therapy on the day of surgery, it'll be a little bit of a modified program. We're going to do a little bit of exercise, check the strength in your muscles to make sure that we think you're appropriate to get up out of bed and start to take some steps and put weight on your leg. The pictures kind of demonstrate a therapist helping somebody use a walker for the first time, and also doing some exercises in this picture on the right. But again, we're going to start the exercises. We'll teach you some transfers out of bed. If you have had a hip surgery, we'll teach you how to do or work within what we call your hip precautions. There are a few things that you won't be able to do with your new total hip right off the bat, and I'll talk about that again in a minute here. But we're going to teach you how to do all these things. We'll be teaching your pal or your family member, your friend, so that they can assist you if necessary. And we usually, again, see you twice a day. Now, if we start your therapy on the day of surgery in the afternoon, if you're doing well enough when we're getting you up, our primary goal that visit is really to do a little exercise and then to get you up into the chair so that you can sit and get your lungs expanding and get out of that bed. That day we'll see you just once, and then the nurse will be the one to help you back to bed after you've sat in the chair, maybe for your dinner meal, that kind of thing. Are you good? Now, on the second day, which things are a little different since a lot of our doctors are seeing patients or having patients get up on the day of surgery. The second full day of therapy. So after we've seen you, you've had surgery, you've had 2 therapy sessions on that first day, morning and afternoon. We're doing your exercises, progressing your walking, again, doing more with the walker, out of bed activities. The second day, we take you to our therapy room, and it's further down the hall on that same floor. And as you can see here, in our room, we have some stairs. So if you do have steps to enter your house, or you have steps, like I said earlier, to a second floor of a home that you need to be able to do to get to your bedroom and your bathroom, we'll be practicing the stairs. We have a set of 4 stairs, as you can see, with rails. We also have large platforms that would simulate maybe a porch or a step into a door or something from the driveway up a sidewalk. So if you have enough room for a walker, we have platforms that we can simulate that. So we'll kind of try and do whatever you might have at home and practice that with your stairs on that second full day. Also, while you're in the therapy room, we have about 3 of the exercise tables that you see there on the right, and we'll do your exercises out of the room and in the hall or in the gym, progressing the exercises, increasing your repetitions. That exercise table, just like the hospital bed, can be elevated. So if you have a tall bed at home and you're concerned about how are you going to get back up onto that bed after the hip or the knee surgery, we can simulate that. So we can make that a higher bed or a lower bed if necessary, so that you're preparing for what you've got when you get to your house. Now, for our total knee patients, Shelley talked about the possibility or probably the probability of having a nerve block. There are 2 different kinds of nerve blocks that the anesthesiologist may do for you, one or the other. And depending on which one they do, we may see sometimes the first day out of bed a little bit of weakness in your thigh muscle. That nerve block is great for the pain control, and it can last maybe 24 to 36 hours. But what that means is if the nerve is not telling the muscle what to do, there may be a little bit of weakness in that thigh muscle that I talked about with the exercises. So when you first get up, you may need some additional help from the therapist, placing maybe a hand in front of your knee to provide some more stability. We always have a second person with us also when you get up for the first time, one of us on either side. And so that is another way that we assist you and keep you safe on your feet when you get up out of bed. Now also for our total knee patients, most of our doctors, not all, but most of our doctors will use what they call a CPM, or a continuous passive motion machine. It is used in the bed, and it gently, your leg rests in it, bends the knee gently back and forth through a period of straightening and then flexion or bending. And depending on your surgeon will determine how often you use the machine. We have some surgeons that use it for 2 hours twice a day, and some of our surgeons will recommend you use it for an hour 3 times a day. And between the nursing staff, and the therapy staff ourselves, we'll make sure that you're in that machine throughout the day when you're not having therapy or before bed at night. And again, that'll be another way to help with circulation, comfort, and flexibility of your knee. Just one more thing. At home, if you've had it in the hospital, our surgeons may recommend it at home as well. Some of our doctors actually have it recommended or prescribed ahead of time, so you might get a call from the company to come out and fit you for the machine before you've come in for surgery. If they haven't done that, then while you're here, they're usually calling your room, trying to find out what day you're going home, so they can set up an appointment to come out to the house and, again, fit you for the machine and determine where you will best place that machine to use at home. Now, for our total hip patients, positioning is key to the recovery of your hip. So there are several things that most of our surgeons will recommend we talk to you about avoiding, and we call these hip precautions. So when you come out of surgery, you may have a blue wedge like this one. We call it an abductor wedge. It is strapped to your leg and your legs are apart. If you don't have that, you might have just a pillow between your legs, but again, it keeps space between your legs so that you do not cross your legs, which is one of the hip precautions. So even when you're up out of bed and we have you sitting maybe in the recliner, we might place just a rolled up blanket between your knees to remind you, especially if you have that habit of crossing your ankles or crossing your legs. That keeps the hip in good alignment by keeping your legs apart and keeping space there. And again, that ball and socket stay more stable where they belong and put you at less risk for dislocation of your hip. Another thing you don't want to do is to bend past a 90-degree angle. Now, this person's standing up. Most of you after total hip surgery right afterwards, you're not going to be bending over to pick things up off the floor. But that 90-degree comes in handy or important when you get up and down out of a chair, off the bed, or off a commode even. So when you get up, most of us don't think about it much. We just bend over and stand up. Well, when I just did that, I bent my hip past the 90-degree angle. You can sit straight with your back. You cannot bend your shoulders past your hips. And you also don't want to bring your leg up to flex that hip past 90 the other direction. So when it comes to getting up out of a seated position, we'll have you put the operative leg forward so your knee is lower than your hip. And instead of bending way forward to get up, we'll help instruct you in practice in trying to push up and come up straighter and then pulling the leg beneath you where you can stand and put pressure on it. So it's not, I don't know that you're going to have the desire to bend right over standing up, but you wouldn't want to do it standing either, but sitting is probably what you'll come across the most with that 90-degree bend. Our occupational therapist, again, I'll talk about in just a moment, but she will be showing you how to use some adaptive equipment, things like long-handled shoe horns, reachers, and things like that, which will help you protect and be independent with your mobility when you're getting dressed and when you're reaching for things, but yet using some adaptive materials to do that. The final hip precaution is that the doctor does not want you to twist your hip or pigeon toe inward. So generally you want your leg to be straight, your toes to be pointed to the ceiling, and when you're walking, we're going to try and help you work on that as well. I know a lot of times before surgery, your feet may turn way out or you may be a little bit pigeon-toed. We'll be talking about that and helping you work through some of those things. They're not going to change overnight, but they are things that we're going to help you work towards keeping more of a midline alignment with your total hip. Those hip precautions also are not a permanent lifestyle change. Your physician will let you know when you no longer need to worry about the hip precautions. Generally speaking, and I would say anywhere from 8 to 12 weeks is pretty typical, but it all depends on how you're healing, how things look for your own recovery in your hip. Now this is the occupational therapy that I was talking about. So OT, they work with you once a day on activities of daily living. So they're going to be helping you with things like self-care, getting dressed, working in the bathroom at the sink, balancing while you're letting go to wash your face, brush your teeth, how you're going to get dressed. And again, especially if you're a total hip patient, using some of those adaptive tools. So you want to have some clothing with you, as Shelley mentioned, to practice those things with the OT. They see you, as I mentioned, just once a day, and they will work with you on some of the equipment. Things that you might have seen in the past or that you might see when you get here, as I mentioned, a long shoehorn. There's a reacher. We have a long sponge to get to the lower part of your legs if you happen to be showering or seated maybe, so that you don't have to bend over and try and figure that out. There are also, and I'll have a picture of it in a minute, but there's something called a sock aid, and a sock aid helps you put socks on. It looks kind of like this, and you'll curl it, put your sock halfway on, and there are straps on the end of it. Once your sock's on there, you throw the straps to the floor, and you'll slip your foot through that tube you've created with your sock and the device. It'll make more sense when I show you, but you'll pull it on, and your sock will be on your foot, and your sock aid is off for the next sock. So again, very creative things that will allow you to maybe be independent if you're concerned about how are you going to do this and don't have somebody who can bend down to help you with your own socks. And even elastic shoelaces. So a lot of this equipment you'll get here in the hospital. If you need it for home, they'll make sure you have it. The other thing is our total knee patients don't always need these items. Again, if you need something, they'll make sure you have it, but they may come in and do an evaluation of your mobility, and because you don't have restrictions like our total hip patients do, you may be able to bend right down and put your shoes and socks on and may never need any of these devices at all. But it's part of their job to come in and evaluate your needs. And as Shelley talked about, pain control is super important. So as I mentioned earlier, you're going to make sure if we come in to see you that you've had some pain medication before we've come. We're going to try and keep you as comfortable as possible throughout your exercises and your walking. We'll make sure you have ice on your hip or knee after we're done, because that's important to kind of calm things down and decrease additional swelling that might occur from activity. This is a picture of an old ice machine that we used to use, but as Shelley talked about, we are using gel packs now. So you'll have 2 sets of gel packs that'll fit into a sleeve. Those can be wrapped around the knee or placed on the hip. We can get additional ice bags if necessary, so just let any of us know, and we'll make sure you have that to help cool things off after exercise. And of course, you'll have rest between therapy sessions. We see you morning and afternoon, and then the OT, as I mentioned, just sees you once a day. Now, in our therapy room and out the one half of the hospital, we put this picture in here just to kind of give you something to think about, and it's kind of a pretty place where people congregate when it's warm and nice outside. But I looked at that further, and I was just thinking, you're trying to all get back to this beautiful, independent level with a beautiful waterfall and everything else. Therapy in the hospital is just one piece to that puzzle. You'll continue with more therapy with home care and then with outpatient therapy to get you back to that independent level. So as I mentioned, it kind of is 3 pathways that are going to lead you back to being hopefully at your best and with a pain-free total hip or total knee. I'm going to talk to you a little bit about home care and outpatient therapy, and then we'll be finished. But going home, just thinking about this before you come in for surgery, think about preparing your home, making it safe, making your pathways a little bit wider for your walker. I'm going to go, I think there's a list of some things, if you hit this, sorry. But again, just as I mentioned, clear your pathways. If you happen to have a hamper somewhere or a trash can that might get in the way of your walker, just think ahead about that. Pet toys, grandkids that might have toys around, I mean, make sure there's a designated area for that out of your way so you can make your pathways clear. There's also, when you get the folder that we've talked about when you come for your pre-op visits, there's a fall prevention sheet in there, and you can kind of go down the list of items that it talks about, again, just to prepare your home. Also, think about your bathroom. How is it set up? Will you maybe need a riser for your toilet seat? Will you have to step over a tub? All those things I like to know in the hospital so we can better practice what your needs are for your home. Do you have rails on your stairwell? Are there, as I mentioned earlier, single steps, or do you have a flight of steps? So all things that are going to be good for us in the hospital, but just thinking about it before surgery and getting your home ready. And as this slide shows, just some different things. The stairwell with the no rails, the bathroom here where you have to step over a tub. For knee patients, it may not be too much difficulty, but if you have a hip replacement and you have to step over a tub with your hip precautions and with maybe a shower door, which limits your space even more, those are things you may want to think about. And sometimes I know people will practice with their home therapist when they first come out to the house to do that shower instead of maybe getting your one leg in the tub and then thinking, how am I going to do this when I can't bend past the 90-degree angle? So again, just thinking ahead, but making sure that your areas are accessible, and if not, telling us so we can help figure out the best ways to make them suitable for your needs after you've gone home. And this slide also shows a few other devices that may be necessary, which we'll talk about, but they have bedside commodes, shower benches, risers for a toilet. They come with handles and without handles. They usually raise your seat maybe an additional 5 inches, which again, the lower you sit, the harder it'll be to get up if your knee's not bending well enough or if you have a hip precaution. And if you are borrowing equipment from anybody, just make sure that you get it home and you clean it and sanitize it so that it's clean for you, that you're not sitting on something that's been in storage for a long time or maybe somebody else has used. Make sure it's clean, again, to decrease that risk of infection. Infection. The other thing I wanted to tell you too about the walker, we'll make sure you have that, as I mentioned earlier, before you leave the hospital. If you aren't borrowing one, we recommend the one with the wheels in the front, and we like that because it will promote a more natural gait pattern as you're walking. Now, when you first get up after your hip or knee, it may take a little more time to get used to putting pressure on your hip or knee joint. You may use your arms a little bit more, but by the time you go home, our goal is to have you walk a little smoother, a little more heel to toe, and you can do that a little better with a walker with wheels. The other type of walkers have generally no wheels, and you would have to lift it and set it down and step. So it's a little harder to get that smooth, continuous flow of gait like you can get from the two-wheelers. The other thing is some of the walkers now, a lot of people have or are borrowing, they have seats on them, and they have 4 wheels. So right after surgery, we don't necessarily want you going that quick. So we kind of slow you down by saying, let's try a 2-wheeler first. You can step closer because there is no seat instead of having to stand behind it and having your back flexed or your hips flexed and being a little bit more unstable. So here at the hospital, if you don't have one, this is what we're going to recommend. And this is generally what we find the safest right off the bat. And you're usually using the walker for maybe a couple of weeks at home before your home therapist helps you progress to maybe using a straight cane and then again showing you how to use that appropriately after surgery. All right, and again, home care, if it's ordered, most of our doctors are ordering home health care after surgery. Again, it's on a case-to-case basis with some of our surgeons, depending on what your needs are. And when you go home, Dr. Perry Jr. does tend to have his knee patients go right from the hospital to outpatient therapy. But if he feels that on your situation you need that additional home health care, he'll order that, and he'll be talking to you about that as well. And usually coming to the house is a nurse and a physical therapist. If you're a total hip patient, you'll probably have occupational therapy as well. The nurse usually comes out for maybe 1 time a week, 2 to 3 weeks that they'll come. They'll work with you and you know, help you coordinate your medications after surgery. There may be some new things, of course, with pain medicine or anti-inflammatories, blood thinners. They will also talk to you about any previous medications that maybe they had to stop in the hospital. So if you were on blood pressure medications, but your blood pressure had been low, they may have stopped that, and you may have to be restarting some of that. So they can help you work with some of your previous medications and make sure you're doing what you need to be at home with your meds. They'll also be looking at your dressings on your hip and knee. They'll be changing dressings. Sometimes they'll remove the staples or sutures, maybe 10 to 14 days after surgery if the doctor wants them to do that. And probably you're not going to be drawing labs as much anymore because most people are not on the Coumadin. But again, if there was any kind of lab work necessary, a lot of times they will be doing that. Blood sugar changes can happen sometimes after surgery just because of the amount of pain that you might be having and that kind of thing. So they can help manage your overall medical status at home and contact the doctor if there are any concerns that they have. Another thing they work with is constipation, which Shelley talked about a little bit, but just making sure that your bowels and your bladder are functioning appropriately as well. And physical therapy, they usually come out a little bit more frequently, usually 3 times a week, again for maybe a 2 to 3 week period of time, a lot of times until you go back to see the doctor or until you're no longer homebound. They're progressing your exercises that we started in the hospital. They're helping you advance, as I mentioned, from the walker to the cane. They'll help you with some balance exercises to help you make that transition to that straight cane. They're going to be helping manage your swelling and your pain control too, to kind of talk to you through that. If you're having trouble sleeping at night, things like that, they may, you know, give you some different recommendations or positions that you might be able to get into to get better sleep so you can function better the next day. They're going to work with you on your hip precautions with more functional activities in your own home. Again, working on your exercises, taking measurements. You may even practice getting in and out not only of the house but the car so that you can prepare to, you know, be that passenger back to the doctor office or to the outpatient center or even behind the steering wheel so that you can prepare for the time that you're going to be driving again. But those are all things that they're going to be helping you with. My goal at the hospital was to get you out of the hospital and home, and now the home care therapist, their job is to get you out of the home and back to the community and maybe to outpatient therapy and going out to eat and to church and all those things again. The occupational therapist, for our total hip patients primarily, they'll continue kind of what they started with in the hospital, working with you with that adaptive equipment for getting dressed. They may work with you also on balance activities, maybe while you're in the kitchen having to load a dishwasher, working at the sink in the bathroom, the kitchen, getting things out of the refrigerator, you know, and having to put things to a table when you've got a walker. How are the best ways to do some of those functional daily living activities? So they're going to continue to work with you on those things as well. A lot of times people don't think about their upper body and their arms, but if you're feeling like, oh, my arms are so tired and sore, you've been using the walker and maybe putting more weight bearing through your upper body, those are things they may be able to address as well. So sometimes they'll set up a little exercise program for your upper body as well. And this is the picture that I talked about earlier with the sock aid. You can see the person sitting in the chair. They've got basically that tube I talked about with the sock on it, and they're holding the straps. Once they've placed it on the floor, that opening for your foot is used, and then you'll pull the straps and the sock will be on your foot, as I mentioned. But it's kind of a handy thing, and once you see it in action, it's kind of cool. Wish you would have been the one to develop that. But anyway, just showing some different items of things that they would work with you on. The long sponge, as I mentioned earlier, as far as reaching the lower leg and the foot. They, if they're going to come to the house, won't come as frequently as the PT, usually maybe 1 or 2 times a week for a couple of weeks. And then just some general reminders for things at home. Hand sanitizer, we talk about it a lot in the hospital, using the Purell, washing your hands, again, keep things clean. Have some hand sanitizer at your house. If people come to visit, or nurses and things have their own, but for visitors, or if you're going to touch your incision or take a look at the leg or have to change any dressings, make sure your hands are clean. You also want to make sure that maybe on your walker you tie a little bag from the grocery store on there that you can toss in there, maybe a bottle of water, a cell phone, so that if you go to another room of the house that all of a sudden the phone rings and you're rushing down the hall. You don't want to have issues where you might lose your balance or be in a hurry to get to that phone when it rings. So again, just things to think about. Also, having a stool softener on hand. They talked about that in the hospital. They start those. But just keeping your bowels moving. The water, keep hydrated. The solution to dilution is pollution. Oh, I said it backwards, darn it. The solution to pollution is dilution. No, I still said it wrong. The solution to pollution is dilution. So anyway, drink lots of water. That was the point of that. Anyway, but ice packs, you'll go home with the gel packs or ice packs that we've used here. If you have any that are in your freezer, they've been there for a while, pull them out, sanitize them. Any kind of ice is good. As you can see here, they even recommend on home care bags of peas or corn, anything that you can easily put on the knee or the hip to cool it down after you've been on your feet a lot, after you've exercised, you've washed dishes, whatever. Use that ice, elevate it, and help cool it off. And then some things that therapy might recommend that you use in the house for your exercises is a cookie sheet under your foot. So if you're doing your exercises on top of the sheet or the bedspread with your clothes on, you may create extra friction between you and the bedding. Having something smooth under your foot to slide upon a lot of times can take that friction away and help with your pain. For our total knee patients, a belt robe that you can loop around your foot to kind of help bend that knee and stretch the knee when you're not having therapy. We'll show you some things you can use in the hospital too that'll help with home for that. I showed you the coffee can, again, just being creative with something you might have at home that is about 6 inches in diameter that you can place beneath your knee and work on that knee extension exercise. And again, I think I've touched base on all those things. The therapist that comes to the house may have some ideas that maybe you weren't thinking about to make those exercises easier. She may have some things that she can leave with you to, again, help you through that home program that we started in the hospital. And then just remembering, I mentioned a moment ago about elevating your leg. After a knee replacement, you don't want to prop your knee with a pillow and just lay that way all night long. The knee will be in that flexed position like it is over the roll. And when you finally remove that, the back of the knee, those muscles can become short and tight, so it'll be hard to get the knee flat. So if you're going to elevate your leg, you want to use pillows to prop almost the whole leg up, so a little bit under the thigh with that pillow, and put it lengthwise instead of putting just beneath your knee. And then while you're elevated, again, using the ice. That helps to reduce that swelling, and that'll improve your flexibility at that knee joint. Also, you want to make sure that when you leave the hospital, maybe fill your prescription on the way home, or have your pal drop it off at the pharmacy, then go take you home, go back and get it for you. That way, you will have your pain medicine when you need it. Sometimes you go to the pharmacy and maybe they don't have the medication that you need, and it takes a little extra time to get that. Also, maybe before you leave the hospital, take your pain medicine, so that buys you a little bit of time, maybe 4 to 6 hours before you need your next dose of medicine. But just things to think about. The loose-fitting clothing that Shelley talked about earlier for our knee patients, something that we can pull your pant leg up and look at your knee as we take measurements, look at the color, the swelling, that kind of thing. For our hip patients, loose-fitting around the hip, because that incision, that dressing is going to be a little bulkier along with swelling. So just make it easy for yourself. Things that have elastic waistbands are usually the easiest. And again, shoes, if you're going to wear shoes in your home, bring your shoes with you. We can work with you on the elastic shoelaces. We may want to practice with the shoe horn, putting those on and off. Gives you a little more stability when you're up walking as well. And a lot of people will tell, or have told our home care staff, expect to tire quickly, okay? You've had a major knee surgery, you're in pain, you're maybe not eating as well as you would like to right now or as you normally would. You may be, again, having trouble with your bowel and bladder a little bit. You're going to get up in the morning, do some exercises, do your getting dressed, your bathing, eat your breakfast, and then you may be pooped out. You may feel like you need to sit and rest. It's completely normal to feel that way. You're going to have to not only build your strength and your mobility back, but your endurance a little bit. So don't be frustrated with yourself. Patience and time will help you heal and achieve that independent mobility. And again, with our knee patients especially, you have to do your knee stretches and your exercises to regain that flexibility. If you wait for the pain and the swelling to go down, things are really tight, the scar tissue is starting to develop, and that scar tissue is not pliable and doesn't stretch like your muscles do. So it's important to start that early on and just be motivated to do that for your full recovery. And just a picture, just again, they're just saying here, have you tried icing it? Any kind of icing is good. So even the kind you eat there. All right. And then finally, just a brief moment about outpatient therapy. Most of our total knee patients will be referred to outpatient therapy, and you'll go to a clinic continuing with exercises, balance activities, working on maybe agility if you're trying to get back to a certain activity, golf, that kind of thing. They're trying to help you return to maybe gardening, walking a longer distance with good normal gait pattern. You may be trying to work with the kids, so you're needing to do different types of transfers, or maybe your goal is to be able to get on and off the floor. They're going to help you with those higher level activities. They also have equipment to use for strength training. They have bicycles, treadmills, things that'll help work to get you back into the community, back to work, back to that activity that you have been limited with all this time because your joint has been more painful and maybe not as flexible. So the doctor's office will generally give you a prescription to take to outpatient therapy. You can go to any facility of your choice, providing, of course, your insurance is taken there. But if you've been to a facility before where you've worked out maybe before your joint replacement surgery, that's suitable. If not, your home therapist may give you some recommendations as well. If you're not familiar with therapy places in the area, your doctor may be able to give you some recommendations. But a lot of our knee patients go for that therapy. And some of our total hip patients do as well, just again, depending on how you're progressing on your home care and what your physician feels your needs are after your home visits have stopped.